Welcome, everyone. It's a pleasure to continue the invited lectures of the Josep Carreras Leukemia Research Institute. And today we have with us Dr. Francesc Bosch. Francesc Bosch graduated from the medical school, University of Barcelona, where he did also his PhD there, working in cyclin D and already in chronic lymphoproliferative disorders. From there, he moved to the US, where in the lab of Professor Ricardo de la Favera at the Institute of Cancer Genetics at Columbia in New York. He went back in 2000 to Barcelona and Catalonia and Hospital Clinic, and since September 2009, he's the head of the Department of Hematology and director of the Experimental Hematology Laboratory at the University Hospital Vall d'Hebron here in Barcelona. And he also has a joint appointment at the Vall d'Hebron Institute of Oncology. He is well known like an authority in the molecular, cellular, and clinical aspects of chronic lymphocytic leukemia, where he's also currently chairing the Spanish CLL working group. And he's, in addition to have published many papers in this area, he's also very, very involved in the clinical trials dealing with CLL. And I'm sure that many new drugs are going to be approved in the coming years, thanks to the effort of his effort and his team. So the title of his talk will be Mechanism of Disease Progression in Chronic Lymphocytic Leukemia. Francesc?
Thank you, Manel. Thank you for your introduction. So during the following, I would say 30-35 minutes, I will cover what we know on what we did on analyzing cell progression in CLL. Let me see if I can move. Yeah, those are my disclosures. And this is the outline of my talk. I'm going to cover first the microenvironment effect on progression in CLL. Second, the VCR signaling and the role in progression, and then more translational part covering the relevance of microenvironment and the PCR signaling in prognostication and therapy in CLL. So let me start with a context. I know the audience is very heterogeneous. Just a few comments on the background of the disease. So we are going to talk on CLL, chronic lymphocytic leukemia. This is the most frequent leukemia in adults in our countries. 5 new cases per 100,000 inhabitants per year. And this disease is defined by a proliferation of mature CD5 positive immune incompetent, so those cells are not competent, B lymphocytes. So there is this expression of a T cell marker or an activation marker, which is CD5 in this disease. And by definition, by the WHO classification, you need to have more than 5,000 clonal B lymphocytes to have a CLL. It's a disease of the elderly. The median age at diagnosis is around 70 years, and the survival is very long. Actually, we don't know now the real survival because we have many new drugs, very active drugs in this disease. So we still don't know the real survival, which is probably longer than 12 years, which is written in the books. And unfortunately, we don't have a curative therapy, although around 30% of the patients will never require therapy. And this is an outline of the progression of the disease. We are going to talk about progression. So you see here what is called MBL. MBL is an entity where the patients have less than 5,000 lymphocytes. So it's like a precursor on a pre-malignant CLL. And 1% per year of the MBLs evolve to CLL. And those CLL, 70%, as I mentioned in the previous slide, will require therapy. So patients will evolve to an advanced stage requiring therapy. And 30% of them will not evolve to, or will not require, eventually will not require therapy. Starting from that, patients are treated with chemoimmunotherapy, BTK inhibitors, BCL2 inhibitors, or are transformed to a more aggressive disease, which is called Richter transformation. So you see here the trip of a patient with a CLL journey, and what we're going to cover now is what's going on in this progression, which factors are dictating the progression of our patients. So let me start with the genetics. During the last 10 years, and thanks to the new methods of sequencing, we know the landscape of CLL, and this is a slide summarizing what we know. There are many mutations. I would say that 80% of the patients you can find a mutation in a driver gene, but the number of mutations or recurrent mutations is very low. The most frequent genetic abnormality here in the top is deletion of the 13q chromosome, followed by SF3B1 ATM, but you see the percentage is quite less than 10%. So a lot of mutations, we know, but we don't know exactly if there is a gene provoking this disease, and we don't have a recurrent genetic abnormality in the CLL cases. So I can group those mutations in this slide, grouped by function. And the most frequent mutation is involving Notch1. This mutation in Notch1 affects the PEST domain, so it affects the possibility of internalizing to the nucleus. And that mutation is different from acute lymphoblastic leukemia, T phenotype. The mutation in ALT is appearing in the receptor, and here in the CLL, the mutation is affecting the PEST domain. So it's a different kind of mutation, preventing the degradation because it's affecting that domain. And if you summarize the mutations affecting the RNA processing, probably they are the most frequent because 1/4 of the patients have some mutation in RNA processing. And finally, there is well-established mutations affecting the gene repair, which is p53 and ATM. But again, you see in this legend that the number of mutations in those patients are very low. So how is the clonal dynamics in CLL during the progression? This is a summary. This is summarizing many papers on that, analyzing longitudinal papers, and the number of mutations that are acquired during the progression is very low. So actually, we are not explaining the progression of the disease due to the mutations. As I said, the acquisition of mutations, the fitness of some clones is almost the same at early stages and when the disease is progressing. So therefore, we are hypothesizing that perhaps other factors, let's say, for instance, the microenvironment, are dictating or helping the progression of the disease. Microenvironment is very important in CLL as it is in many diseases. CLL cells are interacting with many cells, and this is well established. Endothelial cell, T cells, what is called nurse-like cells, follicular dendritic. So the interactions are critical for the CLL survival. Without those interactions, the CLL cell doesn't survive. One example is if you put CLL cells in culture, they don't survive. You need to put some stimuli to keep the cells alive. This is the first example of the need or the requirement of the microenvironment signaling for the survival or the fitness of the cell. On the other hand, circulating T cells from patients exhibit an increased proportion of dysfunctional and exhausted antigen-experienced cells, and those cells are characterized by high expression of inhibitory receptors, PD-1, CD244, CD160, impaired proliferation, and cytotoxic activity. So, and on the other hand, there is defects on immune synapses with leukemic cells. So those cells that are those T cells from the patient are not well functioning compared to healthy cells from the same age and the same gender. So this is the background. We know that there are immune evasion mechanisms in CLL, and we know this mechanism. This has been well described, particularly in T cells, but also myeloid and NK cells. So the mechanism of immune evasion have been well described. So with against this background, we are hypothesizing that perhaps there is a more exhaustion in T cells. This has not been well addressed, the exhaustion compartment in CLL, and perhaps looking at the whole picture, we are envisioning a model of tumor. Sorry, I have to go back. A model of tumor and host immune cells coevolution. So perhaps a clonal diversification of the CLL cells might result from cell autonomous mechanism leading to the merge of fitter clones with bulk CLL. So host immune cells perhaps are co-evolving with CLL cells, creating initially an anti-tumor response, but those CLL cells promote immune evasion mechanism, and they are escaping from this control. For instance, altered antigen expression, presentation, or induction of immunosuppressed microenvironment. So our question is whether we can find tumor and immune microenvironment coevolution from diagnosis to clinical progression. So there is any evolution of the immune system from diagnosis to this progression, and perhaps this evolution is not appearing in patients that are not progressing. So recently we published, actually we are still in the proof analyzing the proof. So this is just coming from the oven. We analyzed the immunological and genetic kinetics from diagnosis to clinical progression in CLL. And for that, we collected longitudinal samples, which is very difficult and unusual in these diseases. So we have samples from diagnosis and samples from patients that are progressing. Same patient, longitudinal samples. So we are avoiding different factors of confusion. It's the same patient at different time points. And also we collected samples from patients that didn't progress. So we collected those samples at certain time point. So the characteristics, we collected 25 patients that progressed and 13 that didn't progress. And the clinical characteristics are quite similar. The median age is similar, and time to the second sampling is actually more or less the same, around 30 months. And with those samples, we analyze the genetic evolution by whole exome sequencing and immunological changes by flow cytometry and functional analysis in both B cells and T cells. So let me start with the whole exome sequencing. As I said, we performed this longitudinal analysis in paired samples from 12 patients with a median rate of death around 120 times. And we look for clonal shifts, analyzing the CCF. And we found that 50% of the patients had a change on the clonal cell fraction. However, half of the patients didn't change the clonal cell fraction. So we go deeper with that. We perform targeted next-generation sequencing with the 9 most frequent genes mutated in CLL. And again, we confirm that those patients didn't acquire additional changes. So we have a bunch of patients that don't acquire genetic abnormalities in this longitudinal analysis along the time. So then we move to the T cell compartment. There were prior analyses in patients diagnosed with CLL that shown an increase in defective circulating CD8 T cells, displaying a terminal differentiated phenotype. So we performed longitudinal analysis. Nobody performed that before, analyzing these memory B cells, effector memory B cells in CD4 and CD8 T cells. I'm showing you the memory B cells with these inhibitor receptors in CD8 compartment. You see here in patients progressing that is an increase. Those cells, the CD8 effector memory B cells, are expanding with these inhibitory receptors when the patient are progressing, compared to those patients that are not progressing. So we have here some clues of what's going on. There's an expansion of these effector memory T cells. We also analyze the CD45 cells, the MRAS CD8 with PD-1 positive, and again there's a progression and expansion during the progression compared to those patients that didn't progress. So there is some here you have an example. There is some like here some instances of what's going on in the memory compartment T cell, CD8 T cell. Again, these cells are increasing, presenting accumulating cells with inhibitory receptors. For instance, CD160, there is an increase in those cells. So first thing, there is an increase in this effector memory T cells in those patients. So in order to analyze what's going on, we look for what's happening with the terminal differentiated or terminal exhausted CD8 positive T cells. So we analyze what is called the progenitor subset that is characterized, as you well know, by TBET, high expression and low expression of hyomas, and the final, those cells you can rescue them, and then the real final terminal subset that is hyomas with high expression. So we found that patients at progression, they show a low number of the progenitor exhausted T cells, and patients that are not progressing, there are no difference, although the figures suggest maybe an increase of the progenitor exhausted T cell. But in contrast, conversely, we found that in those patients that are progressing, there's an expansion of terminally, so the final process, terminal exhausted CD8 T cells related to progression, and we didn't found that in patients that are not progressing. Then we analyze, we perform some functional studies looking co-culturing the T cells from patients with healthy donors and T cells from patients with CLL patients, and we found that the percentage of PD-1 positive, CD8 positive cells were increasing when you culture T cells with B cells, so suggesting that there is an interaction, and that interaction is inducing this T cell phenotype of the CD8 cells. And we found that co-culturing, as I said, the T cells from patients with normal B cells, with BCLL, and also T cells from healthy donors co-culture with BCLLs. And then we look at the mechanism that is driving this increasing of this effect that we are seeing in the co-culture. And we checked whether there is a contact effect, or maybe using transwells, there is some effect. And we found that there is no difference, suggesting that there is some secretion of some products that are inducing this effect. So it's not just contact, but also some secretion of probably some interleukin. So we look then the expression of IL-10, and we found in plasma of patients that are progressing, we found an increase of expression in patients that are progressing compared to those that are not progressing. And again, we found that the CLL cells that are positive for anti-IL-10 are significantly higher in patients with this progression compared to the patients that are not progressing. And if we inhibit IL-10, we found a diminishing of this inhibitory signal, PD-1 in CD8 positive cells, suggesting that IL-10 is in part responsible, is one probably of the responsibles for this phenotype, that this inhibitory phenotype that we are observing in T cells. So the conclusions of our first paper that I'm showing you is that genetic evolution in clinical progression from early stage is uncommon. We found some genetic evolution, but it was quite rare. Effector in memory, EM antigen experienced T cells, probably particularly CD8 cells, accumulate at clinical progression. They increase the markers of exhaustion and dysfunction. And finally, the CLL cells at clinical progression have an enhanced capacity to induce exhaustion and exhibit features of CD8 T cells, partially by increasing capacity to secrete IL-10. So with that, we move to the BCR signaling and the role of BCR signaling in progression. We didn't check that in that paper, so there are many instances of the importance of BCR signaling in CLL. And one of them, as I said before, the CLL cells don't survive in culture, so you need something. And if you stimulate the BCR, you can get proliferation of the CLL. So the CLL is essential for maturation and is dependent of the BCR signaling in the cell. So somehow the CLL cell is mimicking a normal B lymphocyte. So there are many papers and clinical examples of the importance of the BCR signaling. One of them is we published with Marta Crespo many years ago. We published very well the role of SAP70 protein. SAP70 is an ectopic protein expressed in CLL cells, and we found that this protein that is activated by the BCR stimulation is predictive for progression in cells. Patients that have this mutated BCR are doing much better than those patients that have a more functional and unmutated BCR. So again, another example of the importance of the B-cell receptor in CLL. So we performed some additional studies some years ago by Eva Kalpe from our group, that is no longer, unfortunately, in our group, analyzing what's the real function of SAP70, this ectopic expression in CLL, and we analyzed some effects. First, we found we started transfected vertical lymphoma cell lines with SAP70, and we found that upon IgM stimulation, so upon the BCR stimulation, there is an increased signal, so like a redundant signal of the phosphorylation, particularly AKT and ERK. So this, our hypothesis is the ectopic expression of SAP70 in CLL is doing a redundant effect upon BCR stimulation, and this is proved by the fact that, for instance, that the IgM, when we stimulate IgM in SAP70 positive cells, IgM is moving towards the membrane and is staying longer than compared to the cells that don't have SAP70. So this is helping to increase the signal to the IgM signaling. So it's helping to the proliferation of the cell. This is not happening with IgD. So we found that with IgM. And more interestingly, there are effects on cytokines and structural proteins that are dictating the migration and the signaling of the CLL cell. So we compare the chemokine receptors of the cells that are wild type and transfected with SAP70, and we found that transfected cells had an increased expression, particularly of the CCR7. And when we linked the CCR7 with its ligand, the CCL21, we found that cells higher signaling upon the ligation with the CCL21. And this is translating to an increased migration in the Transwell experiment. SAP70 positive cells are migrating more through the CCL21 thanks to this increased CCR7 expression. So in another paper that we published after that, we found that also SAP70 enhances infiltration via CXCR4. You know that CXCR4 is expressed in bone marrow, and we injected ZAP70 positive compared to the wild type Raji cells in a mice model, and we analyzed the survival of those mice, and the mice that had ZAP70 expression had more infiltration in bone marrow and other tissues due to this ZAP70 cell, and this was due to the CXCR4 that was CXCR4 mediated, because when we inhibit CXCR4, the survival of the mice model was longer compared to the ZAP70 that was not inhibited with CXCR4. So we conclude that again, this BCR signaling through the ZAP70 positive expression is detecting the infiltration in different organs, which is what we are observing in the clinical practice. Those patients with more active BCR than mutated BCR with high ZAP70 expression have more bone marrow infiltration. So to summarize these BCR effects on the CLL, we can say that patients with IGHV mutated with a low signal of the BCR are usually low or negative ZAP70 expressed. They have low proliferation, and they have low secondary lymphoid tissue infiltration. And if you have this ectopic ZAP70 expression, that we don't know why those patients have this ectopic ZAP70 expression, but this is redundant with the original protein, which is sick, so they are doing this redundant effect. And those patients with high ZAP70, they have this tonic BCR signaling, they have more proliferation, and they have more secondary lymphoid tissue infiltration, CCR7, CXCR4 mediated. So another effect was to look at the dependence on the culture of the CLL cells, and with Noelia Porrey, that is now in Boston, we performed these experiments culturing CLL cells with different stimuli, particularly IL-4, oligonucleotides, CD40 ligand, and we found that those patients that are expanded, that are proliferating, they have more expression of ZAP70 again and CXCR4 protein. So again, those cells that are proliferating have this phenotype characteristic of the BCR expression. And the final instance is that some oncogenic effect of ZAP70. We found that ZAP70 CLL cells are having an expression of one of the few MIR that are oncogenic. It is MIR-T1, and we found that when we in CLL cells with high expression of MIR-T1, they have a low prognosis. And if we stimulate ZAP70, the system that I showed you before, we found an increased pre-MIR and MIR expression, suggesting that ZAP70 is having somehow again an oncogenic effect on the CLL. And this was, sorry, I have to go back. This was finally proof looking at the effect of the ZAP70 stimulation and the MIR on the MIR target genes, particularly PTEN. So we found that this an increase on PTEN expression upon ZAP70. So let me move to a more translational effect on that. So what's the relevance of the microenvironment and BCR signaling in the way we are managing and prognosticating patients with CLL? This is a more clinical part of my talk, showing what we are doing. We are doing classical translational lab, analyzing samples and translating that to our patients. So we found that there are some variables that are able to prognosticate or to determine who's gonna progress when you are diagnosing the CLL. So there are many variables that are predicting the progression. There are laboratory values, sub-70 expression, as I mentioned before, status IGHV, some genetic abnormalities. Those are samples of biological variables predicting the risk of progression from early stages to advanced stages. And when we visit patients, some of the patients are asking, okay, I'm going to progress or not? So we have the possibility to have this glass ball to determine whether the patient is gonna progress or not. And you see here the genetic, the value of the genetic abnormalities. There are many genetic abnormalities predicting the time to the first treatment and the overall survival. As I said, there are many, but when we analyze this in a high number of patients doing multivariate analysis, the most important genetic abnormalities dictating the progression are p53 and the lack of mutations in the IGHV genes. So all those, the rest of the genes are disappearing probably because those genetic abnormalities are super strong. So this is helping us to determine some scores to predict the progression of our patients, and maybe the most famous score is the CLL-IPI International Prognostic Index that was recently published, and you see here an example of the use of that IPI. We weight the presence of different variables, p53, beta-2 microglobulin, and so on. And thanks to that, we can determine the risk of progression of those patients. You see here, for instance, patients with a low risk, so they don't have variables, adverse variables, they don't progress, so the risk of progression at 10 years is very low compared to those patients with very high risk, where those patients are progressing in less than 2 years. Again, ZAP70 is predicting that. You see here, positive ZAP70 cells, patients tend to progress more rapidly than patients that are exhibiting low ZAP70 expression. And more recently, last year, there was another multivariate score analyzing different clinical and biological variables. And among all these variables, again, in the multivariate analysis, we just can identify a mutated the presence of lymph nodes and the lymphocytes. This is helping us to, again, predict the progression of patients from early stage. So with PowerBrisqueta, we perform a project to analyze the value of the gene expression, because gene expression has been analyzed many times ago by gene expression panels with expression profile, but that was not useful in the clinical practice. So we decided to analyze the value of the gene expression profile by using NanoString in order to predict time to progression in patients with CLL. So for that, we analyzed NanoString in 154 patients. That was our training cohort, and we validate the model in a cohort from Heidelberg, sorry for the misspelling here, Heidelberg, into 121 samples. And we found a score of 15 gene signature. That is, this signature is related to the BCR and the microenvironment signature. So this is the workflow. Sorry for moving too fast the mouse. We found this 15 gene that here you can see this genes, the expression of these genes related to the low risk of progression, intermediate risk, and high risk. And you see here the mutational status of the IGHV genes. And there are some correlations, particularly the high risk is usually appearing in unmutated IGHV, but it's not matching exactly. So probably this CLL-30 score with these 15 genes predicting the progression analyzed by NanoString is somehow complementing the prognostic value of the IGHV mutational status. And here you can see that what I mentioned, the risk of progression using this NanoString set. That is, you can find a low, intermediate, or high risk subgroup of progression in those patients. And this is in the training cohort and in the validation cohort. So the profile is almost the same, and and more interestingly, if we combine this CLL-30 score, analyzing these genes from the expression of these genes related to microenvironment and the VCR with the IGHV mutational status, we can find that we are complementing that. So we are helping to refine the prognostic value of a classic parameter, which is the IGHV mutational status, a parameter that is not always easy to find or to determine because it's technically complex for the laboratories dealing with the patients, and there are around 10–20% of the cases that cannot be determined. So we have a new score that is probably going to be relevant using a standard technology, which is NanoString, to help to determine our patients. So this score is, as I said, improving the capacity when we compare that score with other prognostic parameters. This is the CLL-30. You see here the C statistics, CLL-30 mutational status, early IPI, the paper that I mentioned before, the combination. And if we combine CLL-30 and early IPI, we have an excellent C statistics to predict the progression of our patients. And why do we need to assess the prognosis at early stages in CLL? First is patient counseling, and as I said before, patients are asking us whether they have a high-risk disease, and we can determine the frequency of the visits. If the patient has a high-risk profile, we can visit more frequent or more often the patient at our consultants. And the second thing is to design risk-adapted treatment at early stages, and there are many trials, and we have a trial that are leading in Spain, that is this early stage CLL. We are selecting patients based on these scores and randomize those patients in observation, or giving them a BTK inhibitor like acalabrutinib in order to delay the progression of the disease. So there are practical implications of this activity, of this determination of the prognostication of risk of progression. So in summary, microenvironment and VCR signaling are critical for CLL progression. There are several genes that are influencing the clinical behavior of the CLL. We can determine an accurate gene expression profile by NanoString that should be useful for prognostication. And in my view, we have to integrate this transcriptomic, mutational, probably epigenetic landscapes in order to assess prognosis. We are analyzing different sets, and I think in the future we have to integrate all this information in order to assess the prognosis of our patients. What are we doing now in this line of research? We are moving to mice models. Marta Crespo, when she was at Columbia University, performed a knockout mice of the 13q14 and MIR1516. These are the most frequent genetic abnormalities in CLL, and this deletion of this region in mice is somehow recapitulating what we are seeing in patients. So those mice are developing MBLs, they are developing CLLs, and also developing lymphomas. So the deletion of this region, that is a very complex region in the mice, because actually we couldn't delete or couldn't separate LU2 and MIR1516. So this is including both. So what we are doing now is in these mice, we are looking at again we have these mice in the lab, these knockout mice, and we are checking the immune behavior, the immune evolution, immune dynamics in those patients that are developing MBL, CLL, and non-Hodgkin lymphoma, compared to the mice that are not developing that. So we will have the clue whether those mice are having an impaired immune system due to the appearance of the CLL, or the other way around. This immune system is helping to the progression. And finally, we are in these mice, we are testing different drugs, acalabrutinib, ibrutinib, to see the immunological effects in this mice system we are developing. And this is going on. This is a project that is already going on for a couple of years, and we still don't have results. So I'm finishing here to thank all my department, everybody's collaborating, particularly Pau Brisqueta and Marta Crespo, also Eva Calpe, Julia Garabia, Isabel Jimenez, that performed the papers that I show you. Our collaborators in Valencia, Salamanca, in the Dutch Cancer Center, Ricardo de la Fabre from Columbia University, and the Spanish group of CLL that I am honored to direct. So, and thank you very much for your attention.
Thank you very much, Dr. Bosch, for the great talk. So, and to organize a little bit the questions here. So, one question related to what is the relevance of sub-20 expression in the response of the CLL patients to BCR targeting therapies?
Yeah, that's a good question. Actually, all the patients respond equally to the BCR targeting therapies, which is one of the advantage of the use of ibrutinib or acalabrutinib, because independently of this IgHV mutational status, all the patients respond equally. So, so the response is exactly the same in sub-70 or sub-7. The other thing is the speed or the dynamics of progression. When the patients tend to fail to the therapy and progress, those patients with sub-70 or unmutated JHV that have more active BCR then progress more rapidly. But the response to the therapy is the same. So you are blocking the BTK, and the patients respond equally. And the same is we can apply to the PI3 kinase inhibitors that we are using for our patients as well.
Another related to sub-70, how sub-70 impact the tonic signaling?
Yeah, well, that's a good question. Actually, in CLL, there is in unmutated where sub-70 is expressed, there is always a tonic signaling. So we know that upon IgM stimulation, the cells are having more proliferation, are having more when they have sub-70. So it's increasing this tonic signaling that we are seeing in the CLL. So it's kind of redundant. There is SIK already, that is the same family. ZAP and SIK are from the same family of proteins. SIK is there, but the presence of sub-70 is increasing or enhancing the signal through BCR, this tonic signal.
Yes, you mentioned in your lecture that there were some alterations in ATM in the CLL. Has been this explored in the therapeutic setting, like in PARP inhibitors, etc.?
Yeah, there are some ATM abnormalities. Actually, the most genetic abnormality is 11q deletion, and this is affecting ATM. But in some patients is affecting another gene that is there, that is BIRC3, that sometimes is mutated, and they have bad outcome as well as ITM mutations. So in terms of standard therapy, chemoimmunotherapy, ITM is important. Those patients respond very bad to chemoimmunotherapy. But in terms of new therapies, again, these new therapies are not working through the genome repair. So it doesn't matter whether you have an ATM mutation or not. The BTK inhibitors or BCR inhibitors are acting at the same way. As per the question of the olaparib and all these PARP inhibitors, there are trials going on, but we don't have data on that yet.
What is the current status of CARs in CLL?
This is not related to the talk. CAR T cells. CLL was one of the first diseases where CAR T was explored. The results were encouraging. There was like a 15–20% disease-free survival after the CAR T infusion. But the effect of CAR T is not excellent in CLL, and this is due to the things that I already explained, due to the enormous T-cell exhaustion of the T-cell compartment. So the strategy for CAR T in CLL now is going towards to change the T-cell compartment using different drugs. There are, for instance, trials using ibrutinib. Ibrutinib is diminishing the number of or diminishing the T-cell exhaustion, and there are trials combining ibrutinib with CAR T in order to improve the activity of the CAR T cells. Because, as I said, when you do an apheresis of the patients with CLL, what you get is super exhausted, terminally exhausted T cells, and those cells are very difficult to expand in the patient. So it's still a challenge, the therapy of the CAR T. So yeah. So far it's considered an very experimental therapy.
Yeah. Yeah. You mentioned in your talk also that in the beginning that the longitudinal analysis, you found very few genetic mutations there. So this can be a role then of epigenetics, as has been proposed?
Yeah, there are papers. Actually, I know that there is a paper going on analyzing also the epigenetics, an international paper that we had the opportunity to review. And yes, there are epigenetic profiles related to the cell of origin and the cell that are evolving, and the fitness of some subclones that are the ones that are evolving. This is super interesting, and I think we have to refine that. Unfortunately, from the translational point of view, when you have a given patient in front of you, you don't need profiles, you need black or white. We need a binary decision, and to move that information to the translational is still difficult. But yes, there are epigenetic changes, particularly related to the cell of origin and the fitness of the clones that are expanding during the progression.
So then, so this 30% of patients that do not require therapy, what is the reason for that?
Yeah, there's a classical question that we have to explain to the patient, because the patients are coming to our consultancy with the diagnosis of a leukemia, and we have to explain to the patient, okay, go home. And the patient is saying, okay, I'm lost, so I already dead, and the reason is not. So we know the reasons are different. One is that there are some guidelines, specific guidelines where determining when we have to treat our patients. So we need what we call an active CLL. So that means that there is proliferation, increase of lymph nodes, anemia, so some clinical complications. The second reason is that we don't have a curative therapy, and all the therapies are inducing adverse events. And more importantly, all the therapies are inducing clonal selection. So you don't cure the patient, but you are selecting resistant clones. So you have to give the therapy when the patient requires the therapy. If not, you're going to get resistant clones. And the final reason is there are many clinical trials comparing early therapy compared to observation, and there are no differences in survival. Probably and some of the patients that are receiving therapy, early therapy, are doing worse because of the adverse events. So all in all, so far, we are not treating those patients. I know that this, from the oncological cancer point of view, is surprising because you have a tumor, you are leaving the tumor to evolve. So you cannot think that in breast cancer, for instance, so it could be a disaster. But in CLL, that's a situation that we have. We know if we have a very effective therapy that with low adverse events, then we are going to treat the patients at the beginning.
Yeah, well, it's sometimes it happens in solid tumors, like a prostate cancer that's growing very slow. So it will be a similar scenario probably. The therapy will be worse probably in that patient.
So you don't get advantage in giving an early therapy. So it's the same example. Yeah.
So because we don't want to take more of your time on a Friday, so last question just for me, because what are the consequences of the mutation in IgHB, the downstream consequence of that?
Yeah, so there are many. So the BCR is signaling less, therefore there is less proliferation. The cell is more benign, I would say. There are less genetic or there are less driver mutations in the mutated GSV because they are not signaling very well. So if you have an unmutated GSV, the signaling is fantastic, and then you get more proliferation and more fitness of the B cell.
And then why do you think that is selected? If it confers less proliferation, so you think in a very simple manner. So why then it's selected?
Actually, the issue here is that either you have a mutated or you don't, or an unmutated. So we are talking about probably a different origin of the CLL. Such the classical theory is that there are two origins of the CLL. You don't have a case that is mutated and then becomes unmutated and the other way around. So the hypothesis is that there are different origins, or the cells are derived from a progenitor, and some of them are going through the germinal center, acquiring mutations, and some of them are maturating independently of going through the germinal center. And you have cases that are mutated, so probably those cells are deriving from a progenitor that didn't go through the germinal center. But you don't have both. There is no selection. You have a case that is mutated or a case, and this doesn't change along the course of the disease. So there are kind of two CLLs, two different CLLs.
Understood. Okay, I think we should end here. Let's thank the speaker for the great lecture. Okay, until next time.
Thank you.
Goodbye.
Thank you. Thank you to all. Bye.